Thank you. Thank you for the invitation. Yes, I'm Lorenzo Pini, working at the Department of Neuroscience. I will change a little bit the topic, because this is a clinical story, not a very computational story, so I'm a little bit out of the topic, but still linked. If I show you this picture, I guess everybody can guess. It's a brain. So we have now technologies to see the brain in vivo. It's like a machine for making picture, changing a little bit. Well, most of you are physics, so you can tell better than me that changing the parameters, we can see different tissues. Now, this is a very great tool because we can see the brain in vivo, how it's done in a physiological condition. If you are not a neurologist, I guess that you can imagine that this is our pathologies. We can see in this brain, basically that we have atrophy, even if you are not a neurologist or expert. Here we can see that there is something weird, something that should not be present. It's a brain tumors, and this is a stroke. So, nice tool. We can see brain in vivo, how physiology and pathophysiology. But now the story is a little bit more complex, because even if you are a neurologist and super expert, I challenge you to guess who, between patient 1 and patient 2, is an Alzheimer's disease patient with an atypical presentation, which means that the onset was not memory. Alzheimer, we know that the typical onset is a memory symptoms. I challenge you, it's very difficult even for a super expert in Alzheimer's disease. I challenge you, if you are an expert in brain tumors, to tell who is going to survive more between these two patients. Or if you're an expert in stroke, who is going to recover from the deficit. So even if with looking at the structure of the brain, we have a super great tool, still there is a missing piece in the puzzle to understand pathologies. As lab, personally, I do macro scale, basically macro scale imaging. I think that connectivity is one piece of the story, because basically when we look at the brain and we look at the pathologies, we have to consider that in the brain there are some rules, like gravity from the universe, that are general for all the pathologies. Because even if it's a stroke, it's a tumor, or it's Alzheimer's disease, the way the brain is organized in terms of connection, this is going to influence the pathology, which is tumors, Alzheimer's disease, so different pathologies, but the same rules, which is the connectivity. Now, when in an MRI, just to give a very brief overview what I mean for connectivity, so I'm speaking about functional MRI. Functional MRI, so we can assess differences in the oxygenation of specific brain regions that we are investigating. So this is the typical cascade. So when we are doing, and that is used more for task. So fMRI traditionally, if you think about fMRI, or if you are familiar, you are thinking about people doing something in the scanner, and we can register what is doing the brain. And the brain, what is doing it is when we are doing something, speaking, watching a movie, brain regions that are doing the task show this typical signal, which is I'm increasing the usage of oxygen. So I'm consuming more because I'm doing something. And with the MRI, we can assess the difference over time about this intensity between oxygen, oxyhemoglobin, and the oxyhemoglobin, which means that is bringing or not the oxygen. But what we have to focalize is here. Because even when the brain actually is in a resting state, so people are in the scanner apparently doing anything, well, there are some differences in the signal, which even the amplitude is much lower, but the signal is still changing. The brain seems that it's still doing something. And this is not noise, because this is organized in a specific way. So even when the brain is doing anything, it's consuming energies to keep a structure, an organized structure. And we know that the brain consumes 20% of the metabolism of our body. So something that the weight is 2% is consuming the 20%. And this consumption is done, most of this consumption is when the brain is doing anything, when it's at rest. And there is this organization. So even if you are not familiar with this, which is a functional connectivity matrix, you can see an organization. And the brain is organized even when we are doing anything. Another way to look at the connections is using diffusion MRI, so looking at the displacement of water molecules between the specific regions. And with these techniques, I don't want to go into detail, but basically we can assess in vivo the organization of the tissues that can have a low anisotropy, which means basically the water molecules can displace randomly, or there is a structure again. So there is axons, which can, so the displacement of water molecules is some way constrained. In this way, we can reconstruct the fibers of the brain. So we have activity, and we have basically the structure. And so this is the organization, macro-scale level organization of the brain, which is relevant for our disease. So in this way, we can look at the brain as a railway system, where we have railways, which is the structure, and we have the traffic, the trains, which, let's imagine the trains which are traveling over this system. Now, what is important in the context of the previous image that I showed you, Alzheimer, glioblastoma, or brain tumors in general, and stroke? Well, because this general organization is influencing the pathology. Let's think about Alzheimer's disease. We know that Alzheimer's disease is characterized by accumulation of misfolded proteins, amyloid and tau. Well, the way amyloid and tau will spread and is organized in the brain is not random, but exactly follows this organization. There is a good match between the probability of seeing the spreading over time in our patients of amyloid compared to the organization of the brain at rest. If we move to brain tumors, which is a disease completely different from Alzheimer's disease, the only things that is in common is the brain. Well, again, we have a structure. Here we have the railways that can influence in some way the spreading or the way the cells, cancer cells, can move and can spread over the brain. Then we have stroke. Stroke is not a real brain disease. It's a cerebrovascular disease. The brain is the host of the disease. Again, we can imagine that stroke is focal, but it's not so focal, because when we have a focal damage, we have this disconnection of this region, but we know that this is going to influence the whole network. So basically, the brain connectivity, so for this brain disease, a network story, the title of my presentation, because the connectivity, or the brain networks, is the scaffold, basically, of these pathophysiological processes. I will use just glioblastoma as an example, of what, just to reinforce this assumption. Glioblastoma. If you read the guidelines, medical guidelines, for prognostic factors, age, performance status, some genetic mutation, there is no guidelines today that take into account the brain. So, from the medical guideline that you can read, there is anything about the prognostic factor that can take into account the location of the tumor. It means that each brain tumors, the localization is treated exactly in the same way. But if there is this organization in the brain that can influence the pathophysiology, we should see a relationship with the prognosis. And this is what we have done in a super simple way. So what we assume is, let's assume, I travel every day by train, and I come from Bassano de Grappa. Maybe Bassano de Grappa is not familiar for most of you, but if there is a problem in Bassano de Grappa, I'm the only one who will stay in Bassano de Grappa. People from Milan and Rome can travel. But if there is a problem in Milan or Rome, I will know, for sure, even if I'm from Bassano, because it's a hub, basically. Now, I know this is a stupid example, but this is something that we translate in the brain. So if I have a brain tumors in Paris, in the network, which is a hub, or Berlin, well, this is going to influence in a dramatic way the pathophysiology and the spreading. While if I have the brain tumors in something similar to Bassano de Grappa, well, probably our hypothesis was that the network and the system would react in a different way. So using this type of example from a hypothesis, now translation, the idea was brain tumors growing in a high-density fiber location will have lower prognosis compared to brain tumors growing in a peripheral hub. How to do? In a super easy way, because basically we don't need the diffusion imaging, so what we call advanced that I showed you before, but we use a normative one. So from more than 1,000 healthy controls, we build the organization of the network. And for each patient now, using the MRI that I showed you at the beginning, the clinical MRI, so we are not asking to our patient to do something more, we just extract the 3D dimensional tumors, and we include this now in the normative tractogram. And now we have a number. The number is very simple. It's the number of fibers encompassing this region, which is, if you think, is what we do every time we do blood test, because our exams is compared to a normative distribution. So this is, we compare to a normative distribution. To make it simple, what we found is that compared to the prognosis factors from the medical guidelines, this super simple way to compute, to transform the brain tumors is highly predictive of the overall survival. So we can say, in 87% of accuracy, the prognosis to our patients. So if we go back to the first image, how to do which of the patients can survive more, well, now we have an instrument. We have an instrument because now we are considering the tumor, this pathology, in relationship to the general rule of the brain, which is, in this example, is a macro-scale organization. So basically, this allowed to move from the idea that if the tumor is bigger, is worse, because here it's not a matter of lesion size, but it's a matter of white matter, it's a matter of connection. And this gave also an idea of the spreading of the tumors, that is not random, but can follow these connections. And if we go to a completely different disease, Alzheimer's disease, which is not related to cancer, but is these misfolded proteins, to make it shorter, we know that Alzheimer's disease is characterized by accumulation of amyloid and tau, and in the brain, this accumulation, as I told you at the beginning, is not random, but it follows specific connectivity trajectory. And what I think is wonderful is that this is not true only for Alzheimer's disease, but this is true also for Parkinson. Some months ago, they published a paper in Nature, people from WashU, demonstrating that there is a network problem. Parkinson is a network problem between subcortical region and motor cortex. Huntington disease. This is a degenerative disease, genetic. So completely different. Again, the way the distribution of this misfolded protein, Huntington here, follow other specific networks. And this is not a new idea. Back to 2013, Warren conceptualized the molecular nexopathy model. So a different disease, we have the beginning of the insult or the epicenter of the disease will follow the spreading according to the networks, and then all the disease after, at the end of the disease, they will converge because the disruption will follow. At the end, they will converge. This is important also because in terms of Alzheimer's disease, the question is, but when this connectivity becomes important very early. And there is this paper from Quiroz in this village, which is called the Pueblo del Alzheimer, because there is the highest concentration of genetic Alzheimer's disease, where they found that this connectivity, even in children, could be relevant in terms of the pathophysiological distribution of amyloid pathology. So very early. And so if this is very early, well, now we have something that we can think, we can figure out. It's a proof of we can create proof of concept for therapies. Because if we wait for Alzheimer's disease or for brain tumors, if we wait that the disease is at the end, it's probably too late. So we have a tool for intervention, and we conceptualize, for instance, these are proof of concept. We can include, going back to glioblastoma, brain tumors, now we can include the connectivity in surgery, radiotherapy. So instead of considering each brain tumors independently by the system, we can incorporate the system information in our therapies. And this is something that we can do even in Alzheimer's disease. These are some works that we have done in collaboration with Chiesi Farmaceutici. So the interest in brain network is also moving to pharmaceutical companies. And these are people that I would like to acknowledge, people indeed from Chiesi Farmaceutica. I work with Maurizio Corbetta at the Padova Neuroscience Center. I did my PhD with Giovanni Frisoni at Brescia, and these are some collaborations that helped me. And thank you for your attention.